Hello there. Today we're going to be talking about hyponatremia, a condition where sodium levels in the blood are lower than normal. And as we dive deeper into the causes, symptoms, as well as treatment options, don't forget to hit the subscribe button and let's get started. So, understanding hyponatremia is indispensable because it is the most common electrolyte abnormality in the hospitalized patients. Hyponatremia is defined as serum sodium levels less than 135 milliequivalents per liter. So, in the evaluation of hyponatremia, yes, you are right, it is crucial to measure serum osmolality. This is very important, and I'll explain this in detail very soon. This would help you to distinguish between hypotonic, isotonic, and a hypertonic hyponatremia. Additionally, urine analysis is also essential as it provides information on urine osmolality and also the urine sodium content as well. Furthermore, it is necessary to check serum electrolytes, and this would include the potassiums as well as chlorides. And not only that, of course, the total body water content is also necessary as this would help assess the patient's overall hydration status. Now we'll take a closer look at what osmolality is and how it relates to the sodium levels. Sodium itself contributes significantly to concentration, but the topic is hyponatremia. And so we're going to take sodium out and compare it with the resultant concentration. So hyponatremia means that the sodium levels would always be decreased. And we will compare this with the concentration. And here concentration is what replaces osmolality. The definition of osmolality is concentration of osmose in a mass of solvent. And this is usually expressed as milliosmose per kilogram of water. So in fact, the expression which is in mass, that is kilogram, this is why we call it osmolality. You might have also heard of osmolarity. And this term is used if the representation is with volume, or let's say liters. So if it is expressed as kilogram, it is called osmolality. If it is expressed as volume, it is called osmolarity. So the next thing is that we're going to check the concentration or the osmolality. If the osmolality is less than 295 milliequivalents per liter, we will call it hypotonic hyponatremia. If the osmolality is within the normal range, 280, 295, we will call this isotonic hyponatremia. If the osmolality level is greater than 295 milliosmol per kg, we will call this hypertonic hyponatremia. So how did we arrive at these formulas, which gave us these figures? So there is a formula that you see right here, which is the osmolality of the plasma. And you can see that sodium, as we said, is very, very important for the determination of osmolality. Not only sodium, but also glucose as well, right? Now, this formula is going to be the general or the osmolality of the plasma. There is another formula you are looking at on top, right? But before I explain that, let me just give you one example. Let us say that we have a compartment, and this part is going to be, say, the ECF, that is your extracellular fluid, and this is your intracellular fluid. Now, let us say you have sodiums here, and you have potassiums, and you also have glucose. You understand that these solutes are tightly regulated. In other words, they do not freely cross the membrane. They are regulated. Sodium goes in and then it is exchanged for potassiums. or glucose has transporters which gets glucose into the intracellular compartment. And so these solutes are only moving in and out and they are tightly regulated. So because of that, we call them effective osmoles. Potassiums, sodiums, and glucose, they are effective osmoles. So the formula that you see right here, this is an effective osmolality. And as you can see, there is the absence of blood urea nitrogen. Why? Well, the reason is that blood urea nitrogen would rather freely cross the membrane. And so it is an ineffective osmole. And this is why you hear of effective osmolality as well as ineffective osmolality. It just tells you which of these solutes determines tonicity. So for example, if you increase the sodium levels at this compartment, then you're certainly going to increase the tonicity or the concentration of sodium in that compartment. If you increase glucose levels, you would also increase tonicity. If you increase potassium levels, you increase tonicity. So these are very effective osmoles, and blood urea nitrogen is an ineffective one. So in the next slide, we'll break it down and take it into details. We will start with hypotonic, and then we will proceed to isotonic, and then hypertonic hyponatremia. All right, so once you encounter hypotonic hyponatremia, it is essential to prioritize volume status. Volume status. This is important in the evaluation as this can help guide further classification and even management. This approach allows you to consider whether the patient's hypotonic hyponatremia is related to hypovolemia, for example, euvolemia, or hypervolemia. In hypotonic hyponatremia, this is characterized by a low sodium concentration in the blood, typically caused by a loss of the sodium salt, either through the renal system or a non-renal route. So let's take the renal system. For example, there can be a membranopathy where the kidney would waste the salt. Moreover, in aldosterone deficiency, you recall that aldosterone usually binds to a receptor and it will activate some channels that we call epithelial sodium channels. And this will help reabsorb sodiums. So in the absence of aldosterone, sodiums do not get reabsorbed. And so this can lead to a hypotonic hyponatremia. So alternatively, the sodiums can also be lost through non-renal routes such as burns, skin losses, gastrointestinal tract disorders, which would lead to vomiting, diarrhea, for example. Now, once that happens, this would lead to a net sodium loss. So we have hyponatremia. But once this occurs, there is going to be a hypovolemia, right? And this hypovolemia would even worsen the hyponatremia. Let's take a look, because once there is a hypovolemia, this will activate TEST and also would activate the release of vasopressin. And once vasopressin is activated, there is going to be an increase in water reabsorption. Once water is being reabsorbed, this will cause an electrolyte-free water retention, so that the water would increase whilst the sodium remains the same or gets reduced. So there is a dilution of even what is already left, and this would worsen the hyponatremia. So the signs of volume depletion may be subtle sometimes, but this may include a range of indicators that collectively signal a state of inadequate fluid levels. This may actually include tachycardia at rest, orthostasis, a decreased skin turgor, dry mucous membranes, and hypotension can all be indicative of volume depletion. A decrease in the jugular venous pressure may also suggest a decline in the central blood volume. In euvolemic hypotonic hyponatremia, there are absence of signs indicative of volume depletion or expansion. This may include syndrome of inappropriate antidiuretic hormone secretion, medications, primary polydipsia, hormonal changes, especially hypothyroidism and hypercortisolism, Stress and respiratory impairments may lead to euvolemic hypotonic hyponatremia. So here we're going to take a look at hypervolemia in the face of hypotonic hyponatremia. So in hypervolemia, of course, there is a volume expansion, and this occurs in congestive heart failure, liver cirrhosis, nephrotic syndrome. Now, the important thing to note is that there is a reduction in the effective circulating volume. We are not saying the volume is reduced because we do understand that there is a volume expansion, but we are rather saying that there is a reduction in the effective circulating volume. For example, there is an increased preload in congestive heart failure. This is a reduction in the effective circulating volume, for example. Now, this will certainly lead to an increased vasopressin state. If you recall, this will lead to excessive reabsorption of water, and the total body water will then increase. That is, the total body water will be more than the total body sodium. And this will to dilute the sodiums and lead to a hypotonic hyponatremia, which is the hypervolemic state. Isotonic hyponatremia. So the plasma contains about 93% of water. In that 93% of water, as you can see, the sodium ions are dissolved. The rest, that is about 7%, is made up of proteins and lipids. So let's say in a disease such as multiple myeloma, where there is excessive proteins, or in a disease such as hyperlipidemia, you increase the proteins and the lipids. This will shift the 7% to, let's say, 30%. Now, this will create a false decrease in the sodium levels, and we call that pseudo hyponatremia. It occurs in hyperproteinemia as well as hyperlipidemia. Hypertonic hyponatremia. So we have the intracellular compartment. We also have the extracellular compartment. And you recall that the sodiums are mostly in the extracellular compartment. If you create an osmotic gradient by increasing the level of glucose in the extracellular compartment, or let's say mannitol, sorbitol, glycerol, or radiocontrast substances, you create an osmotic gradient. That is, you increase the osmolality in this compartment, that is the extracellular compartment. What will happen is that water will then shift from the intracellular compartment into the extracellular compartment. So you dilute the sodiums that are in the extracellular compartment. This is how hypertonic hyponatremia occurs. All right, so in hyponatremia, you want to ask yourself a very simple question. Are the sodiums lost as a result of a renal problem, or are they lost as a result of a non-renal problem? So here we're going to take a look at the fractional excretion of sodium. And this is actually equal to the ratio of sodiums that are excreted. As you can see, this is going to be the ratio of sodiums excreted to the ratio of sodiums that are filtered. So we could actually say that the fractional excretion of sodiums is equal to the ratio which is excreted to the ratio filtered. Now here, an important question is that if you have a low volume state, okay, and you have a normal GFR, that is a normal renal function, then the kidneys should be able to enhance the reabsorption of sodiums if there is a low volume state, meaning that in a hypotonic hyponatremia, where there is a low volume state, the kidneys would rather decrease the excretion of sodiums, that is the sodium levels in the urine, and this would lead to a fractional excretion of sodiums being less than 1%. The only exclusion is that if the patient is using a diuretic, for example, or if there is a low aldosterone state, then this fraction may change. All right, because in that case, if you have a low aldosterone state, you recall that aldosterone binds to a receptor, and then what happens is that it increases the sodium reabsorption. So if there is no aldosterone, then sodium reabsorption would actually be low, of course. And in that case, the excreted sodiums in the urine will be high. So the only exclusion is if there is a diuretic use or if there is a low aldosterone state. Other than that, in a low volume state where the kidneys are normal, hypotonic hyponatremia would have a fractional excretion of sodiums being less than 1%. Now, conversely, if the fraction of sodiums are greater than 1%, well, and there is a low volume state, then this could suggest that there is an impairment in the tubular function and there is a likely decreased ability of the kidneys to reabsorb sodiums. So in that case, you can see that the sodium levels are greater than 20 in renal impairments, and it is less than 10. Some books would also say 20, less than 20 in non-renal causes. So the initial rule of treatment of hyponatremia, regardless of its underlying cause, should be managed with caution, and this is to avoid excessive correction, which can actually lead to osmotic demyelination syndrome. And a safe and a conservative approach is to give not more than 0.5 milliequivalents per hour. In other words, if you are giving 0.5 in a day per hour, then you should certainly not exceed 12 milliequivalents within the 12 to 24 hour period. The recommendation guideline is to give 4 to 8 millimole per day. So caution must be taken, especially in contingents who are at risk of osmotic demyelination syndrome, otherwise known as central pontine myelinolysis. Factors to consider when you treat the patient includes the underlying cause, whether the hyponatremia is acute or chronic, the volume state, and it's also necessary to assess how rapid the sodiums are lost. So in acute hyponatremia, symptoms are primarily neurologic, and this may include nausea, vomiting, forgetfulness, malaise, lethargy, headaches, confusion, obtundation, stupor, seizures, and coma may also ensue if hyponatremia is rapid and severe. So acute hyponatremia is rather a life-threatening condition that requires prompt correction due to its high risk of brain herniation. The condition is often symptomatic and demands a rapid treatment to prevent the devastating neurological consequences. To achieve this, some guidelines recommend a bolus of 100 ml of 3% sodium chloride solution administered intravenously, which may be repeated and monitored for symptoms to resolve. Conivaptan and tolvaptan are vasopressin 2 receptor antagonists, and they have also been approved for the treatment of symptomatic euvolemic and hypervolemic hyponatremia. They work by inhibiting the action of vasopressin, and fludrocortisone may be used in salt wasting. Now, in contrast to chronic hyponatremia, symptoms may be minimal or even asymptomatic, as the body has already adapted to the reduced sodium levels. Hypovolemic hyponatremia, on the other hand, can be managed by intravascular volume expansion with a normal saline in addition to treating the underlying cause of the fluid loss. Hypervolemic hyponatremia can be managed through a combination of fluid restriction, diuretic therapy, and addressing the underlying cause. Now we can take a look at when to suspect a syndrome of inappropriate antidiuretic hormone release in a patient who has hyponatremia, who is euvolemic, increased urine osmolality, hypouricemia, and a normal renal, adrenal, and thyroid function, plus any of the usual causes such as a malignancy, pulmonary disease, such as a central nervous impairment. The threshold to consider SIADH must be low in such cases. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.